to the Stay in Medicine podcast. I'm joined today by Dr. Elizabeth Ebwing. So Dr. Ebwing is a board-certified family physician currently serving as an assistant program director to a family medicine residency program in Delaware. She went to UCLA for undergrad, received her master's from California State Polytechnic University, and completed medical school at the American University of the Caribbean School of Medicine. Then she went to Philadelphia to complete her residency in family medicine under the Drexel University Family Medicine Residency, where her focus was on community and underserved care. I have had the privilege of knowing Liz for now 4 years. She is absolutely a doer. She's innovative and a connector. And for those patients that have had the privilege of having her as a provider, as well as other colleagues, we all know she is deeply compassionate, caring, and a brilliant physician, as well as an amazing educator. So Liz, thank you so much for spending time with us today. Before we delve in, I do want you to talk a little bit about your route to medicine because it's a little bit untraditional. So let's start there. Tell us about your route to medicine.
Sure. Well, thank you so much for having me on this podcast, Janet. Super excited to be here and join you today. So non-traditional definitely describes my route to medicine. I think for those that may not be familiar with the traditional route, generally many medical students will go through undergrad with some kind of science major, go directly into medical school, and then start residency right away. To be perfectly honest, I did not think I would ever be a doctor. Seriously, if you asked me, 15 years ago, if I would see myself as a physician, I would have laughed at your face. And I think a lot of that was I just never really envisioned that. And the prerequisites to get into medical school, it's math and science. And so I got my degree in American literature and culture
Mhm.
and was really set on never having to pick up another, science or math textbook. Um, so I got my undergraduate degree and I thought I was going to do something in either education or law. And so I actually volunteered at the Superior Court in LA
Oh,
in
wow.
family law.
Mhm.
Yeah. And it was great hearing people's stories, but it was missing an aspect. There was just a lot of paperwork. And I knew that it just wasn't the right fit for me.
Mhm.
And so I knew I liked working with people, helping people, and I thought that maybe going into education might be a better fit for me. So I actually got my master's of arts in education at Cal Poly
Mhm.
Pomona. And during that time, I actually was working just to pay the bills, basically.
Mhm.
And so I was doing project management work, and I met my now husband
Mhm.
there, and we actually both went to the same undergrad and just happened to land in the same position for the same reasons. And we literally had dinner one day, and he told me that he wanted to pursue medicine and that
Mhm.
I should join him. And I laughed in his face, like literally laughed in his face. But we started talking about it more seriously because, each of us in our, respective families had family members that were going through various health issues. And
Mhm.
we just knew that there was a space for us to be able to help explain things to our family members and help them make better decisions for themselves. So that's when I really started thinking seriously about it and went back and took all the prerequisite classes. And to be honest, that took a while because it was really hard to get into, certain classes because a lot of them are for, nursing and other,
Mhm.
allied health fields. And so it took me, I think, 2 years to finish all my prerequisites while I was working, studying for the MCAT, and before, like, I know it, I'm here, you know?
Yeah.
It's crazy. It's so crazy. We um we just finished interviewing for
Hmm.
our next class, and it just blows my mind that, you know, I was once in their shoes, and to think about like all the steps that it takes to get there. It's just
Yeah. Well,
wow.
and for a lot of our listeners out there that feel like, especially for our individuals that are in high school and are in college, for those that think it's too late to get into medicine, it's not. It's
Mm-mm,
not. If
no.
that passion is there, do it, because
Yep.
we need people that
Yeah.
look like me, that look like you, to take
Mhm.
care of my mom, my dad.
Yeah.
In previous episodes, I've kind of talked about kind of how I stumbled in medicine, where I just needed to go to college. Like I grew up pretty poor in the US. I didn't know I was poor until I, I went to
Yeah.
college and I was like, oh, okay. Because I had everything I needed,
Right.
but I knew like I needed to go into college to take the next step forward. Um, but for me, a lot of my experience was translating for my parents and interacting with the medical system. And I was like, you know what? Like this is where I need to be. I need to be an advocate for them. So for those out there that think like, hey, I need to know that I'm going to be a doctor when I am like 6 years old. Not true. Not
Mm.
true. And here we are, amazing physicians, trying to provide care for patients that, at least for me, that look like me, that
Mhm.
maybe, didn't interact with the medical system, or didn't have great interactions with the medical system, and how we can improve that. So tell me, in terms of, given your background, I mean, you went from not necessarily thinking of medicine, then okay, I'm in medicine, like I'm in it, and then going into an inner city program, going into a program that is really focused on community. What was that like for you?
Yeah, so great question. I think once I finally realized that medicine was the right path for me,
Hmm.
I knew for sure that it was going to be family medicine. You know, I think there are people or students or applicants that there's this stereotype that family medicine is the backup specialty, and
Hmm.
people only go into family medicine when they can't get into their first choice.
Hmm.
That's complete BS. So I was so it's funny that you talk about, you know, um, these experiences with healthcare that really turn people off, right? Patients from seeking care. I actually was really fortunate to have an amazing family med doc
Hmm.
when I was growing up, and so she really was my first introduction to medicine in the field. And I just remember how she made me feel, and I wanted to be able to do that for other people, right? Make them feel safe and
Hmm.
comfort them and listen to. And so when I was applying for residency, I I actually did the couples match. So
Hmm.
Mike and I, we were very specific in looking for programs that had that served similar communities than where we grew up in Southern California. And so, but we spread a wide net kind of geographically, and ended up at Drexel in Philly, which was amazing to train at. And so, being a part of giving back to that community and caring for patients that are truly underserved, Hahnemann Hospital was our training hospital, and talked about the whole drama about that.
So,
It,
so with a lot of our listeners, they're not Hahnemann, right? Just to give a little bit of background, has historically been, the hospital that really takes care of Center City, West Philly
mhm,
area, and a lot of the services, are aimed at, really community-driven services. And for our listeners that don't know, so Hahnemann Hospital closed
Mhm.
a couple years. It's been like what, almost 2 years now,
Mhm.
right? Um, and a lot of it was finance driven, but so for our listeners, that was a hospital that gave services to the community. And unfortunately, because of the healthcare system and because of how expensive it is, to provide healthcare, as well as the finances behind taking care of, underserved communities, it was a hospital that ended up, closing. Um, so I just wanted to give, our listeners a little bit of background. But go ahead, in terms of Hahnemann Hospital, like what was your experience there, and how was that in line with the population that you wanted to take care of?
Yeah. So kind of piggybacking on that, the history of Hahnemann. So basically it's the safety net hospital
Hmm.
for the area. And basically nobody was turned away from from care there. And so it was such a great place to train at because you saw such a variety of pathology and you were working alongside other specialties too. And so just from a training perspective, it was an experience that I could not have imagined, but I'm so grateful for, because after taking care of patients that are truly sick, and have a lot of multiple medical problems, can be very tricky to care for. But thinking about like the psychosocial aspect of knowing, as family physicians, we look at our patients holistically, right? So it's not
Hmm.
just the uncontrolled diabetic in front of you that's in DKA, but it's also taking into consideration and, okay, why aren't they controlled? Is it
Yeah.
because they couldn't afford their medication? Is it because they didn't have power to keep their fridge on, to keep their insulin
Mhm.
regulated? um, or sometimes it's making that tough choice where I can't afford insulin this month because I have to pay for food.
Yeah.
So really, having that kind of understanding and appreciation for the patients really helps motivate you
Hmm.
to keep going through those rough days and times, because someone on the other end really needs your help and really needs your care. And the patients are oftentimes so grateful, um, and I think that that honestly is what keeps you going, because medicine is it's not the easiest thing. If it was, everyone would be doing it. But
Yeah.
yeah.
And it's interesting because, as physicians, working at Hahnemann as well for some time, um, patients don't know what's going on. They just know that they can't afford their medications. They don't know that prices are inflated
Mhm.
because of the system that we live in the US. They're not aware, of these services that they can have, but maybe their insurance doesn't cover it because they're underinsured. It is a lot of times we end up being the advocate. We have the bird's eye view. We understand,
Yeah.
what's going on from a business standpoint that really prevents these services for individuals that are of, certain socioeconomic classes, unfortunately, right, in the US. And for me, I went from military medicine where it's socialized medicine. I didn't have to worry about getting people their insulin. They got their insulin,
Mhm.
or if they needed studies, like an MRI, I didn't have to worry about battling, really armoring up. I felt
Yeah.
like, to get them an MRI or to get them the image that they wanted. So for me, entering that, it was a little bit of a culture shock for me. I was like, "Wait, what do you mean we can't give him insulin? Or what do you mean we can't give him, this life-saving drug because it's too expensive and their insurance won't pay for it?" So it really, again, like, brought to light a lot of things that I was very naive to leaving the military in terms of the cost of medicine and the services that we provide. And somehow, when we worked at Hahnemann, it got done. We had a team where they needed that. We figured it out. It got done. So to really see that hospital close down, um, I mean, that hit. I know it hit you, it hit a lot of physicians. Um, really in terms of like just for me, I kind of mourned a little bit, because again, these are patients like my mom, like my dad, that maybe would not be able to get care, or now care is delayed because
Yeah.
they have to go into other systems that have longer wait times. So it was a very interesting experience, and I think for me it awoke you know um really what's going on in the background that's
Mhm,
impacting our care.
mhm, mhm.
So, in terms of your training, because I mean, you came from a community based, a really a training that really focuses on service, and now you've transitioned from being the trainee to the trainer. Right? So now you are, in a position where you're educating others. Um, so tell me a little bit about how your experience as a trainee has influenced now in your new role as an educator.
Sure. So part of our residency training, we have a rotation where we act as junior preceptors.
Mhm.
So I think that experience planted a seed about how I enjoyed working with others. And I think kind of tying back into, my background, getting my MA was actually in education.
Mhm.
And so I think from that really sparked that, oh, maybe I can do this, lifelong. I
Mhm.
found myself every time where I was working with students or, my co-residents and helping them, get that aha light bulb moment, help filled my cup. And it was something that really brought me joy. And so it was an easy decision for me towards the end of residency to really want to pursue an academic position. So becoming the trainer was a no-brainer for me. And also, to be perfectly honest, I guess on a more self-serving reason as well, is because I wanted to be surrounded by others still. I knew that I wasn't going to be the only attending or the only faculty person. And so it brought me comfort knowing that I'd still be surrounded by people that I can, you know, um, tap into for questions and, feedback and advice. And so that really appealed to me as well, and then being able to help train the next generation of family physicians specifically was really
Mhm.
exciting for me. So uh, I was fortunate to get um, a position where I'm at now. I think it's going on almost a year of core faculty where I'm
Mhm.
there 100% of the time. And I still have to like pinch myself, like, oh, this is what I get to do. Like, this is my job. I get paid for
I will tell you, the first couple years, there is that battle of imposter syndrome, but you are where you're meant to be. I mean, I could tell you
this.
just because I've seen you teach other residents, and I've seen you, you know, um, do that sort of work, and you're phenomenal, you
Oh,
know? So I do want to ask, like, there's so much that you learn in your first year as an attending.
mhm,
At least for me,
mhm.
well, I feel like I'm constantly learning. But,
Yes, it's
yeah,
true. That's
but my
medicine.
first yeah, but my first year as an attending, I was like, "Oh, man, did I actually do a residency?" Because there's so much, that I just didn't know. Like, for me, the biggest aha, or the biggest, like, "Oh my gosh," like, I need to really figure out leadership. I need to know the business of medicine. And for me as well, like, there were just things in medicine I just didn't know. I was like, "Oh, man, I've never seen this before," when
Mhm,
I was seeing patients. So now that you're training others, you've had your first years in attending already under your belt, now you're training others. What are the things that you wish you knew, in like maybe residency, or maybe things that you feel, um as an education system, that we don't provide our trainees?
yeah, so I think there's a lot of things that I wish I knew. But I think that we kind of touched upon the big thing is that the whole sense of imposter syndrome, or,
Mm,
am I good enough, or, can I really do this? I feel like that never really 100% goes away. Like some days
mhm,
are better than others. I think in medicine in particular, things are always changing, whether it's new guidelines, new medications to know, new, you know, uh, whatever it may be. Like we'll never know 100% of all the information that's out there to
mhm,
know. And so med students and residents, I feel that we hold our attendings as like be all, know all. And I remember when I was on the inpatient service during residency, and one of the attendings was on service, and I think I questioned him and I was like, how do you know that? And I remember he told me, he's like, what are you talking about? He's like, I look up stuff all the time before I'm always on up to date. And I was like, oh, okay. And it was just very reassuring. Like it reminded me that at the end of the day, we're all human, and we need to, refresh ourselves and look up, and there's nothing
mhm.
wrong with that. There's
There is
nothing wrong
nothing. And in fact, in my mind, that's what makes you a better physician. So it's kind of a dichotomy too, right? So we're the experts of our in our field, but at least for me internally, I never felt like I was the expert in my field because I was constantly learning. I was
Mhm.
constantly looking at new literature. But that's it in medicine. You are the expert of your field, and you will never know everything, you
Right.
know? And that's that growth mentality that is really needed, and that's really required to be an excellent physician over the course, of several years. And I understand now why they call it the practice of medicine, right? Where you're
Yeah.
you're like, there's certain things where, I've never seen, but I'm honest with my patients. Listen, I've never seen this before. I'm gonna get back to you in a couple of days. Let me do my research. And I feel like patients appreciate that. They
Mhm.
feel listened to. They feel like you're not going to miss things, right?
Yeah.
Instead of saying, "Oh, this is XYZ, just try some of this and, come back." No, like the way we were taught, and the way, I know in training, at least the training program that you came from, a lot of it is, okay, we need to follow up on this. We need to keep reading. We need to keep pushing ourselves to know
Mhm.
more. Um, to honor our patients, right?
Yeah,
Um,
definitely. I know when I'm working with my medical students and my residents, that's something I'm always kind of stressing, is that I'm the first to admit that I do not know everything, but part of my job and part of our job as healthcare physician is knowing how and where to find the answer for your patients. And
mhm.
so just having that sense of um, humility, I think, in
Yeah,
acknowledging that we don't know everything, but we're gonna figure it out.
yeah.
And yeah, I feel like patients appreciate that, and you know, I appreciate that from my colleagues to hear that as well. Like, okay, we'll figure it out together.
Mhm.
It's like, okay, phew, it's not just me.
Now, do you feel like, in the system that we're currently in, I know it's always a challenge to find time, right? It's that perception that we're always racing against a clock to get everything done. Um, in our current training programs, in our current system, do you feel like we have that time or space that allows for that, or that time and space to really continue this growth mentality?
Mhm. Yeah, the I think the phrase is the days are long, but the years are short.
Yeah.
Kind of. Is that how it goes? I think that's how it goes.
Yeah.
Because that's how I feel my whole like medical journey has been so far.
Hmm.
When I look back and I think back on it, I think when it comes down to the whole time constraint and talking about pajama charting and whatnot.
Yeah.
I think we're finally at a point where we realize that in order to provide, high quality, compassionate, effective healthcare, we need to have a space and an environment physically and
Yeah.
psychologically where we can thrive and do that. And so the changes that were made with documentation this year for note taking, has been a huge game changer for me, not
Hmm.
having to count every single component to make sure that I meet the minimums for
For
billing and documentation.
billing. Yeah.
Yeah, that was huge. And so I find that I am able to talk to my patients more because I'm not like mentally calculating all those little
Yeah.
pieces. Um, I think is gonna be great once I think my residents still haven't caught up or realized that they don't need to, put every single, surgical social history in it and really focus on the medical decision making on and why the patient is here. I think once that really has been cemented in our practices, I think will help ease that burden because a lot of it is just charting.
Yeah, it's just fluff. I mean,
Yeah.
and it's so interesting that you know point that out because part of at least my mission, is to help physicians, keep seeing patients and really stay in medicine, right? That's the whole point of this podcast. And like my vision, I want to make the environment better so that physicians will stay.
Mhm.
And in the current, or at least previously, for a lot of people that don't know, for especially for primary care, there were different bullets that you had to ask so that the insurance company would pay you back for the work that you did.
Mhm.
So then, a lot of patients complained that their providers were documenting while they were seeing them. They felt that they weren't listened to. Well, of
Mhm.
course, where the mission of the healthcare system and the mission of a physician were kind of at odds. And I mean, to a certain extent, they still are, they feel that way sometimes. But I agree with the new CMS guidelines, with the new guidelines where it say, hey, we just want you to take care of the patient and document really your decision making, and all of these other bullet points that we used to don't matter anymore. For me, I agree. Like, I think that's made things easier. I think we could still absolutely keep improving on that, so that at the end of the day, it's just me talking to a patient. It's
Yeah.
just me delivering that care. We need to get back to that,
Mhm.
some way, somehow. And I think we're making strides to doing that. But it is a change in mindset, that we're going to have to reteach our physicians, and that we're going to have to, you know, um, have a buy-in from our administrators. Sometimes they don't see both sides and somehow meet in the middle. And I
Mhm.
feel like that's what we're all trying to do. We all have, I think for the most part, good intentions, and
Mhm.
we want to provide the best sort of care. Um, but sometimes it's difficult to do so, or when we do it, it is at great sacrifice to ourselves. I can't tell you how many times I've had the pajama time, or I've had to call patients after hours because the way we stack our appointments, right, are just back to back, back to back. And it's, you don't have time to use the restroom sometimes, let alone, right, let alone call a patient back. And I think as a system, we're realizing that, and trying to figure out best ways to deliver care and still be human to our physicians and the people providing, and be cognizant of their needs as well. And it's not like we're asking, at least for me, I don't feel like I'm asking for a lot, but to have that freedom to say, you know what, I need to look this up. This is actually more complicated than I thought, and that 15 to 20-minute visit back to back doesn't allow for that sometimes. So that restructuring or rethinking the way we deliver care, and is going to be critical over the next couple of years, I think, anyway.
Yeah, definitely. I think from talking to colleagues that went into other practices, private practice,
Hmm.
it's exciting to hear the innovations that other offices are doing with scribes. They have like the
Mhm.
Google glasses
Yeah.
that are like, I was like, oh, that's me. And so my hope is one day that's just standard everywhere, to be able to get back to the root of medicine and just
Yeah.
taking care of patients. That's I think why all of us or most of us went into medicine is to be able to take care of people. And so, changes like that, hopefully we'll be able
Yeah.
to do more of that.
So I know for you, you're doing a lot in terms of your resident. You're very humble. You're doing a lot within your residency program to really deliver holistic care, incorporating this social, model and, really integrating medicine. What do you have planned for the future? Like in terms of like what do you see that is your mission over the next year,
Mhm.
or your undertaking to really make medicine just a little bit better for all of us?
Oh wow, that's a big question. Ooh. Uh, so honestly, I think in terms of the next year or two is really just building on the initiatives that my organization has really kind of set up. And I think
Hmm.
a lot of our society these days are also taking a harder, closer look at is just
Yeah.
inclusivity,
Yeah.
diversity. And I think, at least for me personally, is it really kind of just stems and filters down to creating a change in our work environment, work culture,
Yeah.
where it's okay and I want people to feel welcomed in having these maybe tough or
Hmm.
uncomfortable conversations, right? And that's how we learn and that's how we grow.
Yeah.
And just making it and continuing to foster a safe space where we can have discussions like that. And hopefully be able to, recruit others to, join this family medicine revolution. Right. Every medical student that works with me, the first question I ask them is, "Oh, so have you thought about what you want to specialize in?" And it's always my mission to plant that seed and get them to really consider going into family medicine. And I think the beauty of the program that I'm in is it really is full spectrum.
Hmm.
So we're the only residency program in the hospital, and so our residents do OB, they do
They
delivery,
do everything, huh?
prenatal, yep.
Yeah.
And so their first assist on everything. And so students are really surprised about the scope of family medicine, about what
Hmm.
we get to do, about who we get to treat. And so it's really exciting when I see them and like, oh, I didn't realize that, we're hospitalists, urgent care, office space,
Yeah.
there's so many different, practice models that we can go into. And so I think just building on um, that kind of FM revolution, making primary care primary again. Because the statistics. Oh my gosh, I can't
Yeah,
say
yeah.
that.
It's okay.
Statistics. I was just reading the other day that we're by 2025 we'll still be lacking or we'll have a need for 52,000 more
Yeah.
primary care physicians.
Yeah.
That's in what, like just
That's
in
not that far away.
yeah.
Yeah.
What?
And it's so interesting though, because for me, I just feel there's so many barriers
Mhm.
for one to become a physician. There is a significant financial investment. That's seeing it, like you're looking at people going at least 200K in the hole to just
Mhm.
become a physician, right? But then as a system, we're like, oh my gosh, we have this shortage of physicians. We have this shortage, we're really worried in the next couple of years that we're not going to be able to fill it. And we see these holes within our medical system,
Mhm.
but where's the solution?
Yeah,
Like, so you're
yeah.
asking someone to make a leap of faith and go 20, or 200, $300,000 in the hole to get this medical education to fill a need, a real need that we need in society, where you're not really making money until like your what, like late 20s, early 30s, where you're trying to get out of debt, you know? So as a system, we recognize that we need these physicians, but then where is that, you know, that return where you say, listen, come into our field. It
Mm-hmm.
won't be that, we'll help you with the debt. You'll
Yeah,
feel a need that we need in our society,
right, right.
and we've all outlined this as, barriers, at least for me, had I not joined the military, I wouldn't have been a doctor. Well, because I came from very humble beginnings, and, our mentality with finances and savings was very different. So
Yeah.
if I walked into a situation where I knew I would be, you
Mm.
know, hundreds of thousands of dollars in debt, I would have definitely thought twice.
Yeah.
I mean, I thought 3 times before joining the military to pay for it, but it is, we are such aware of these deficits.
Yeah.
Um, but then how do we address these barriers, right? We want more people that are diverse going into medicine. How do we address these barriers that we know exist,
Yeah. And
right?
I think that's one of the things that you're talking about when I was thinking about, this our conversation today, and um, the goal of bringing more underrepresented minorities into the health system, into medicine, and and I would love to see increased loan forgiveness, right?
Right.
Um, and and also for you know kind of across the board, different states offer incentives for
Mm-hmm.
uh, loan repayment and whatnot. um, it's crazy how there's such a mismatch, that there's this obvious need, and so that's why it's so frustrating sometimes, because it
Yeah.
seems like the answer is so simple, but we know that there's like a million other things that
Mm-hmm.
are affecting it. um, I would say though that, and I know it's probably also not necessarily easy for me to say, but I wouldn't necessarily let strictly like
Yeah.
finances hold you back, because if there's a will, there's a way.
Mm-hmm.
And it's just a matter, I think, of connecting to people to help get you to where you need to be. Because if it wasn't for my friends, my family, for Mike, I would not know how to navigate the system.
Yeah.
So reaching out to others, to help you get to where you want and where people need you to be. So financially, yes, it is a big investment, but the return as well.
Yeah.
If medicine is what your heart is set on, is is worth it. It's totally worth it. Mm.
So, in terms of, we talked about this deficit, we talked about, barriers. And for me, now being several years out of training, I'm seeing a lot of my colleagues leaving medicine. They're like, I'm done. I'm done. I'm throwing in the towel. We talked about things that fill your cup. Um, so, what is keeping you in medicine right now, knowing all of this, Um, what is keeping you in medicine? And what do you think as physicians we need to do to hold us in medicine?
Mhm. Yeah, I think I'm a big believer in little victories. So I think a lot of times, I don't think it's unique to my office or anything like that, but we there's always something that could be fixed, that could be better, that could be more efficient, right? And it can kind of snowball into other things. But whenever something like that happens, I try to scale back and think, okay, well, what's something tangible that we can do,
Hmm.
some something uh, an effective change, right?
Yeah.
Whether it's literally like the placement of a basket. so, so building on that, right, and helping people see that that these little changes matter,
Yeah.
right? And also also just let people, sometimes people just need to vent and just get it out, right? So
Mhm.
listening to people and really listening to them and seeing what the issue is. Um, so for example, when I'm just the other day, one of my colleagues, we were in the precepting room, and she suffers from migraines a lot, and so she just said something about um, the text or the size of the font on our EMR. And then I asked her, I was like, oh, have you ever thought about changing the size? And she was like, oh no, you can do that. And so the point of that is just, you know, checking in with your colleagues and seeing
Mhm.
how they're doing. And then also just, you know, reaching out to, when I have questions with our EMR, I'm like, there has to be a way
Yeah.
to do this easier. And so I'll ask around. I'm like, oh yeah, they're definitely gonna use this. And it's like, oh my gosh, game
Yeah.
changer
Well,
right
and it's
there.
so right, and it's so funny, right? When we look at the teams that we work in, I think as a profession, we're so used to like, okay, I got to take care of this. I have to take care of this. And we forget that our team is larger than just the physicians.
Mhm.
We have our technicians, we have IT. I cannot tell you how much we undervalue
Yeah,
that,
I'm a
or just don't
style.
think of IT like as part of the team.
Yeah.
And they really do make things a lot easier when you incorporate them and explain, hey, this is the problem. This is what we're having. This is what's preventing me from doing what I need to do. Can we think through? Can we think through our process? And I think you make a good point that for us, I think these conversations that we have in the workplace regarding our frustrations, we talk about barriers, we talk about all these other things. And the next step to that, and I know you're really good at that, is really empowering yourself and empowering others to start making these small changes that eventually will snowball into larger changes that really impact someone's experience, both on the physician and on the patient end. Like this example that it's a small thing, but for this physician, I mean, you've just saved her a lot of grief, a lot of discomfort just by really broadening that team and saying, you know what, like, hey, let me help you with this. Let's engage with IT. We got to figure out a way to make this work for us so that we can deliver care better. Um, I
I
know
know.
it's, go ahead, go ahead.
No, I was just thinking, I was like, oh, this poor thing, this whole time she's been suffering from these like teeny tiny font. I was like, oh man, I wish I had talked to her earlier about this. I realized it.
And but that proves, the point. Like there are things that we can do in our environments at least for me in my situation. I'm in an academic setting. It is hard, but there are things that we can do to help us stay in medicine, to help us, take care of patients. And no matter how small or how big, these things are impactful,
Mhm.
and they can really change everyone's
Yeah.
experience.
Yeah. I think the other thing that I'm also, I think, realizing too in the position that I am, so my colleagues are such incredibly hard workers. They wear so many hats. And so one of the things when I was thinking about like how I stay in medicine is basically also the value that I have in my life outside of medicine.
Yeah.
And so I remember when I was in residency, we would always make it a point to do some kind of big trip,
Mhm.
regardless of like how much time we had. And so having something to always look forward to. And so when I'm in my new position, I was kind of surprised or how my colleagues just kind of pushed off their PTO or their time away.
Mhm.
And I remember talking to one of my colleagues, and I told him, I was like, you don't have vacation, or you're not taking any time off for like 9 months. I was like, are you crazy? Like, you have to take, especially after our
Yeah.
COVID year, we really
Yeah.
made a point to regardless of whatever plans we had, we're like, everyone has to take, at least, a 3-day weekend
Yeah.
just to mentally, physically, emotionally recharge. And so I think part of that too is also making sure that you are, taking care of yourself and
Mhm.
your loved ones and everything outside of your medical world
Yeah.
too. Because it is easy. It is easy to kind of push that aside when you have, patients that you have to get back to and charts done and, presentations to prepare for. And
Yeah.
it's just, taking a pause and, you know, remember that there's life outside of medicine as well.
No, absolutely, absolutely. And I think that culture of like that delayed gratification and delay, it really sets us up for not taking care of ourselves sometimes,
Mhm.
and absolutely agreed.
Yeah.
Um, so over the next year, hopefully we're out of COVID, although I do anticipate that we have a little bit more to go. With COVID, I feel like it's made me think about the way we deliver care.
Mhm.
You know, so for example, for the next year, I would love to see a little bit of deregulation in medicine so we could continue telemedicine. I
Yes.
actually like telemedicine,
Yes. Same.
right? So for example, I could see people's backgrounds,
Mhm.
so when patients are depressed, I was like, okay, yeah, you're real
Mhm.
depressed. I see what's going on in the background. I said, let me get you some help,
Yeah.
or you could see people's social networks as
Mhm.
they walk by the
Mhm.
camera, as we're trying to do a video visit
Yeah.
with them.
They
You know,
actually have their medicines with them, so they can
yeah,
see
you
them.
could how many times, right? They walk with their phone, let me
Yeah.
go check, and they'll walk to their
Yeah.
bathroom, they'll get, their but for me, I feel like the medical system really has dictated to us the way we should be delivering care. And because of COVID, we've had to pivot, and the insurance has had to pivot with it. And it created a phenomenal opportunity where we
Mhm.
expanded the way we deliver care,
Mhm. Mhm.
right?
Yeah.
And it showed us around the world, like, why are we obligating patients to come in? Like,
Mhm.
why? I know why. Because if we provided telemedicine before COVID, they would have to pay for that.
Mhm.
That's why. And
Mhm.
now that insurances are paying for it, patients are all for it. They're like, yeah,
Yeah.
no, this is great. Like, I can't tell you how many patients will squeeze in a visit before they have to go to class, where before they wouldn't be able to see us, right?
Yeah.
Going to the doctor was like a 2-hour venture. You got to
Yep.
go in, go to the office, find parking, sometimes there's a wait time. And it really took all of that out.
And that's for your patients that have the ability to get
Yeah,
into their car and drive.
that's
Like,
true. For
like,
some, it might be a more hours of
yeah,
adventure if they got to take a bus or they have to take,
yeah,
right.
yeah.
So
So,
for me, I would like to see, physicians look at the way we're delivering care now because of COVID and look at lessons learned. Like, can we deliver care a little bit differently?
mhm.
Lessons learned, um, and really push at a system that really has for me, an antiquated way of seeing patients. Where we're stuck in the offices, really seeing in a brick and mortar, and we're expecting people to come out of their comfort
Yeah,
environments, and like you said, like it's so much easier for them to just get their medications. They're like, oh, doc, I got it. Here
yeah,
it is.
yeah.
Let me run to the bathroom. Let me get, and for me, it's been a time saver, both on the
Mhm.
patient end and as a provider.
Yeah.
So for me, that's kind of, what I think of when, over the next year, lessons learned with COVID, there's change that needs to be, done in our system. And it's evident now. You can't ignore it, can't take it back.
Yeah. No take backs.
No take backs.
No, agreed. I think telehealth has been a real game changer and has opened up access for so many patients. And I think and I'm hoping that it is here to stay because there really is no good reason why it shouldn't be.
Hmm.
So I'm excited for that. Yeah, definitely. I'm glad that's that's part of our
Part of our
tool
repertoire
now.
now.
Yeah,
Yeah. Yeah.
yeah. sure, for sure.
All right. Well, Liz, thank you so much for joining us, for this episode of Stay in Medicine. It is always a pleasure talking to you.
Oh.
Um, um, so for our listeners to hear more, if you want to learn more about our guests, please check out stayinmedicine.com and take a look for us whenever podcasts are available. For individuals that are really interested in continuing to stay or figuring out a way to stay in medicine, make sure you get your copy of Staying in Medicine: How Physicians Can Move Past Burnout and Regain Control on Amazon.com. So once again, thank you, and we'll see you next episode.